Today will probably be the last in your series of asthma, lectures on asthma, part 3. So today we will be covering mainly your management of exacerbations, what is acute severe asthma, and what are the other drugs that we use, and other modalities of treatment. Just a brief overview of two other main modalities of treatment for asthma. So, what is an exacerbation? Exacerbation is otherwise characterized by episodes of progressive increase of symptoms of shortness of breath, cough, wheezing, or chest tightness, with a decrease in lung function. Now, this decrease in lung function, we can objectively, for patients who are at home, if they have their home-based peak flow meter, so at least even your own patients at home will also be able to show will be able to monitor their fall in lung function by noting any decrease. Usually we take a fall in peak expiratory flow of more than 20% to be significant. So an exacerbation basically is any, and in addition it also represents any change in the patient's usual status sufficient to require a change in your treatment that you're giving the patient, and usually occurs in response to an external agent. And common triggers include, for an exacerbation, include viral respiratory infections, allergen exposure, food allergies, outdoor air pollution, and change of season, especially like what we're seeing right now. Okay, so treatment of asthma, of these exacerbations, they can be managed at home or even in the hospital. If they are mild exacerbations, you can always manage them at home through teleconsultation. Okay. So what is home management? Home management is basically ensuring that before, this is something, a written asthma plan is something which every physician should have discussed with their asthmatic patient, even when they're stable, that at the time of exacerbation, these are the things, the signs of exacerbation they should know. They should assess their daily PEF and note down how much is the change in their peak expiratory flow every day. And drugs which can be advised at home is basically the drugs which either they have been taking when they were stable, such as your reliever, inhaled corticosteroid and LABA combination. We can advise them that they can increase their drugs which they're taking, either increase the dose or increase the frequency. They can even take oral steroids if this has been included in the asthma plan. In the written plan, if the physician has already told them that if you have such symptoms, if you feel that your PEF has come down by more than 40%, okay, start oral steroids. So these are some things which, if a plan has already been made, then these drugs can be taken by the patient at home. He need not come to a doctor. And other leukotriene receptor antagonists and such as montelukast, etc., can be taken at home. So basically, self-management or home management of exacerbation includes self-monitoring of symptoms, then medical review. So if there's earlier mild, they can increase their reliever intake, increase the controller medications, and they can assess the response. If there's persistently increase, that is the time when they should contact the doctor. After taking steroids and all, if there's still persistent increase, then they can contact a doctor. So how do they increase their reliever medication? How do they use? Basically, increase the usual relievers. If they're using low dose of ICS formoterol, they can increase the frequency of as needed of the drug. If they're taking short-acting beta agonists, then you can add, either you can increase your SABA or at the same time add the ICS formoterol combination to this therapy which is already going on. And the other is to increase the controller. You continue your ICS formoterol and increase the reliever dose of the ICS formoterol. Okay. Or you can add other drugs such as your leukotriene antagonist. Then oral corticosteroids you can add for severe exacerbation. That is either if your PEF or FEV1 is less than 60%, or the patient is not responding to this treatment above for a period of more than 48 hours. Here you can take usual doses for prednisolone 40 to 50 milligram per day, usually 5 to 7 days. At minimum, we give it for 5 days. Okay, and if it is less than 5 days, we do not need to taper. That is, if we give 40 mg, even after 5 days, you can stop abruptly. There's no harm in stopping these steroids. at that dose. Okay, if we're taking it for less than 4 weeks, the recommended dose right now is actually, the recommended duration right now is 5 days, because studies have shown, studies comparing 5 days versus 14 days have shown that there's no major difference beyond 5 days. The effect of the steroid is not marked after 5 days. So 5 days is a good enough duration to give for steroids. Extending it beyond 5 days just increases the chances of adverse effects from steroids. Okay, so these are home management. Also, this is what you can tell them to do at home. If despite this they're still complaining of symptoms and all, that is when you tell them to come to the hospital. So in the hospital, what should be done? Assess the history. You assess the timing and cause. Look at the severity of asthma symptoms, including any limitation of if asthma has been has caused any limitation of the activities, any symptoms of anaphylaxis. Okay. Examination should be brief, should be focused. Look at vital signs, level of consciousness, temperature, pulse, respiratory, blood pressure, ability to complete sentences or use accessory, any use of accessory muscles when they're talking, any presence of audible wheeze, any complicating factors such as anaphylaxis, pneumonia, pneumothorax. Okay, and objective measurements that you can measure is a pulse oximetry and PEF, or peak expiratory flow rate. Okay, so once it comes to the hospital, you assess the patient for the exacerbation. See whether it is really asthma, whether the patient has any risk factors for any asthma-related death, meaning the patient may progress or worsen very fast, and to assess how severe is the exacerbation. So in mild to moderate exacerbation, the patient will be able to talk in phrases. He prefers to be sitting. Then the respiratory rate is increased but not very high. Accessory muscles are not used. Pulse rate is around 100 to 200, and oxygen saturation on room air is usually above 90%. And the peak expiratory flow rate is more than 50% of his, at least 50%, within 50% of his predicted or the patient's best effort when he is stable. Okay. A severe exacerbation is the patient is unable to talk in sentences, would talk in words. He would be hunched up. Okay, maybe agitated. Respiratory rate is high, more than 30. There's presence of accessory muscle use. That means there may be nasal flaring. There may be prominence of the sternocleidomastoid. There may be intercostal indrawing. Okay, heart rate would be high, and oxygen saturation on room air is usually below 90%. Okay, and life-threatening symptoms. Life-threatening symptoms where the patient is drowsy, confused, or what on examination you get what is known as the silent chest. So in a patient with acute exacerbation of asthma, the presence of a silent chest is an ominous sign. It is not a good sign. It doesn't mean that the patient does not have wheeze. It means that the patient's respiratory muscles have gone into so much fatigue that they're not able to inhale enough oxygen. So that's why if there's not enough air that is moving in and out of the lungs, there won't be any air to produce the wheeze. So in severe asthma, along with these, if there's a silent chest, it is a sign that you have to act fast. Okay, so for mild and moderate disease, what you do is you start treatment, you give either a SABA, or in most cases nowadays, what we prefer is ICS-LABA combination, or even at times you can give a SABA plus SAMA combination, 4 to 10 pounds by pressure MDI plus spacer every 20 minutes for 1 hour. You can, if this moderate disease, you can even start prednisolone, oral prednisolone at 40 to 50 mg, and oxygen if the patient has saturation is less than 90%, but we target a saturation of only around up to 94%. Okay, you continue the treatment with the SABA as needed, because steroids, he's already got systemic steroids, assess the response. If there is worsening, you transfer to a higher center, acute care facility, where there is facility for intubation, for mechanical ventilation, for ICU care, in other words. Okay. And if, however, there is response, you assess for discharge, there's improvement in symptoms, there's the PEF is improving, the oxygen saturation is more than 94% in room air, and the patient also has adequate resources to continue management at home, then you can send the patient home. Okay, now coming to this part where you transfer to the acute care facility, that is from the primary health center, his patient is worsening, then they are transferred to a tertiary center. And this is where our role comes here in the tertiary center. Again, main thing, objective assessments, measurement of lung function is strongly recommended. If you remember in COPD, we know that in COPD, when a patient has exacerbation, you know what the lung function will be. There will be, it's already decreased. But here, the thing with asthma is lung function, if you know it is because the lung function, the changes in lung function in bronchial asthma is very acute. The moment you start therapy, it will immediately improve. So that's why it's important when they come to have a baseline. An easy way to do this is to use a peak flow meter, which is a very small device, is the size of just the size of a pencil box, which can be kept in the emergency. It basically what the patient needs to do is just to blow as hard as possible into that for at least 10 seconds. That will give you the maximum flow rate, the peak, the maximum speed at which the patient is able to generate the breath. And on that basis, we will see, we can at least compare it with the patient's baseline. Oxygen saturation should be closely monitored by pulse oximetry. This is especially useful in children if they are unable to perform PEF. In saturations less than 90% is, it tells us that we need to be more aggressive with the patients. Arterial blood gases, unlike in COPD, are not routinely required in asthma, because most of the time in an acute exacerbation, we will not see the classical signs, classical blood gas pictures like we see in COPD, where there's hypoxemia, where there is hypercarbia. In asthma, actually, because of hyperventilation, because they're breathing out very fast, because of the high respiratory rate, the CO2 will actually be at times less than 40. However, if we have it and we do it and we find that CO2 is high, that tells us that this is a very severe case of asthma, because CO2 retention is a sign of respiratory muscle fatigue. So if the patient retains the CO2, then we know that this is actually quite severe. So it's not always required, but if the facility is there, it is a useful investigation. Again, other imaging such as chest X-ray and all is not usually required in a clear-cut simple case of asthma exacerbation. However, if you suspect that there may be the cause of exacerbation is an infection or something else like that, then if there is a clinical indication, then we can go ahead with these imaging. Okay, because we should not waste time in getting all these imaging and getting all these other investigations and deny the patient treatment. Okay. So, most important thing is if they come to a tertiary care center, we know that they're already quite bad. So, what we assess airway, breathing, circulation, see for any of these things. If there's any drowsiness, confusion, or silent chest, if they're not present, we further triage by the clinical status and according to the worst feature which is present. Mild to moderate disease, similarly, you talk in phrases, prefer sitting, not agitated, and saturation is okay, PEF is okay. Here we can give short-acting beta agonists. Ipratropium bromide can also be added. Saba-Saba combination, we can add, they're available both as a MDI and also in the emergency, we have them as nebulizers. Then we can also give oxygen and oral steroids. Okay, if it is severe, we usually consider IV steroids such as IV hydrocortisone, and we assess the response. If the response is okay, if they are improving after 1 hour, half an hour to 1 hour, we continue with this. If there's no improvement, we can consider adding a high dose inhaled steroid or even IV magnesium. Okay. Now, if there's continuing, if the patient is improving, then we continue with the symptoms, we continue with the same treatment, and then we gradually step down and plan for discharge. However, if there's continued deterioration despite all these treatment, then we'll have to consider transferring the patient to an ICU and be prepared for intubation and mechanical ventilation. So among the drugs which are used in exacerbation, again, oxygen. Here, oxygen is a drug. We should use oxygen as a drug, not as any other support. Our main role to achieve oxygen is to maintain a saturation of 93 to 95. Okay. And usually we give it by a nasal prong. We should not use oxygen. We should not be callous in our use of oxygen. Do not try to achieve a saturation around 98, 99. And another thing which we commonly see is that oxygen, what we see in most emergencies is that they will connect the nebulizer mask to the oxygen and nebulize with oxygen. Now that is not recommended because one, it wastes a lot of oxygen, because when you have to nebulize, the flow of air required is very high. So for that, you increase the flow of oxygen, number one, that extra oxygen is unnecessary and it leads to a lot of wastage. And if with that amount of oxygen, it may actually blunt the respiratory reflexes. So oxygen should not be used for nebulization. Well, if you were to nebulize a patient who's on oxygen, let the patient receive the oxygen by the nasal prong and put a nebulization mask on top, and they can get their nebulization through the nebulizer. Okay, inhaled short-acting beta agonist, which is salbutamol, SABA therapy, is administered frequently to patients with asthma. This is the most cost-effective and efficient delivery is by a pressured MDI and a spacer. Okay, now adrenaline or epinephrine is not routinely indicated for exacerbations unless the exacerbation is due to any anaphylaxis, okay, or angioedema. To relieve the anaphylaxis or angioedema, epinephrine can be used. Now, systemic steroids. Again, the role of systemic steroid is to speed the resolution of exacerbation and prevent any relapse. Systemic steroid should be administered to the patient preferably within 1 hour. And the other indications is when you're already using high SABA treatment and that is still not providing any relief to the patient. The exacerbation has developed while the patient was already taking oral steroids, and the patient has a history of previous exacerbations in the past, which have all required steroid use. So in such cases, it is always prudent to start the systemic steroids early. What we can use orally, 40 milligram, 40 to 50. Usually we give 40 milligram prednisolone once a day, or we can give 200 to 300 mg of hydrocortisone in divided doses. This is usually given IV. Okay. In addition to that, we also have other drugs such as ipratropium bromide. Ipratropium bromide, like I said, is a short-acting muscarinic antagonist, or SAMA, usually combined with your salbutamol for a SABA-SAMA combination. Aminophylline and theophylline, they have a very narrow therapeutic window, and they're usually given IV, and hence the problem with them is that they have a very high potency to cause adverse events, acute adverse events such as arrhythmias and all that. So they are no longer, and are not very effective bronchodilators in the acute setting, but they are no longer recommended for use. But they can be used if it's really bad, but they are not the first line drugs to be used in the emergency. Now, IV magnesium again, there's no strong data, but we have seen that if there is significant, if the patients have severe disease, they're not responding that well to inhaled steroids, they're not responding that well to systemic steroids, then we can add magnesium infusion, single 2 gram infusion over 20 minutes. You can increase it up to a frequency of once a day for 3 days. It reduces hospital admission in some patients. Okay, what magnesium also does is that it stabilizes the airway smooth muscles. Now, helium oxygen therapy. Helium oxygen therapy basically is a mixture of 20% helium and 80% oxygen. Okay, so what helium does to the oxygen is that it increases the Reynolds number of the helium of the mixture, making it more stable. Therefore, that allows the oxygen to reach up to the distal airways. It increases the laminar flow. Basically, it just makes the gas a bit more heavier to ensure that the gas flows in a laminar fashion, because if it is turbulent, it gets dispersed. So in the smaller airways, that way a laminar flow will enable the gas to reach up to the alveoli and therefore improve oxygenation. But again, helium oxygen therapy, number one, it is expensive, and not many centers have heliox in them, so it is not routinely recommended as a first-line therapy. Leukotriene receptor antagonists, again, there's limited role to support them for oral or IV. Usually, we can use them in mild at-home cases. In the hospital setting, we have other drugs which are more useful for severe diseases, because leukotriene receptor antagonists will usually not very helpful in severe disease. Okay, non-invasive ventilation. There's evidence for role of NIV in asthma is not as strong as in COPD. We've seen in COPD and from the past lectures that it is, in fact, nowadays it has become more or less a treatment of choice in acute exacerbation of COPD. For asthma, however, NIV is not really a strong treatment modality, because if we look at the pathophysiology of exacerbation in asthma, also hypercarbia or CO2 retention is not one of the features of asthma exacerbation, whereas CO2 retention is a strong feature in a COPD exacerbation. And the main role of non-invasive ventilation is that it helps in washing out that CO2. So in asthma, where there's not so much of CO2 retention, the role of NIV is therefore more questionable. So in patients who have severe disease of asthma and they require admission into the ICU, usually we prefer invasive ventilation, that is intubation, rather than trying non-invasive ventilation. Okay, so that with acute exacerbation of asthma. So basically, we just need to remember that mild cases of exacerbation can be managed with at home by increasing their usual reliever medication, adding on oral steroids at home, or even adding glucotriene receptor antagonists. Whereas in the hospitals, if they're not responding to home therapy, they need to come to the hospital, and in the hospital we can be more aggressive. We have, in addition to oral steroids, we have parenteral steroids, we have IV magnesium, there's mechanical ventilation that we can use. Again, that will all depend on the assessment that you do and the response to therapy. If the response therapy is good, we can stick with short-acting bronchodilators with inhaled steroids plus oral steroids if needed. Okay, so that's it with acute exacerbation of bronchial asthma. Now we come to another section, which is a common term which is being seen, which is difficult to treat, uncontrolled and severe asthma, whether they are one and the same or whether is there any significant difference in them. So difficult to treat asthma, the definition basically is an uncontrolled asthma basically includes either of the following. There's post-symptom control, that means the patient has frequent symptoms or requires more reliever use, or the asthma is limiting the activity of the patient and he still has nocturnal symptoms due to asthma, along with a history of frequent exacerbations, more than 2 exacerbations per year requiring oral corticosteroids, or at least one serious exacerbation where a patient has been admitted in the hospital. So that's uncontrolled asthma. A difficult to treat asthma is an asthma that is uncontrolled despite step 4, step 5 of your GINA treatment. If you remember the step ladder that we had seen. So step 4, step 5, that is moderate to high dose of ICS plus moderate to high dose of LABA, or you've added a LAMA therapy, or you've added your glucotriene receptor antagonist or other therapies. Despite that, the asthma is still uncontrolled. Or difficult to treat asthma is also asthma that requires such treatment, requires this kind of treatment to maintain good symptom control and reduce the risk of exacerbations. Now, difficult to treat asthma does not mean a difficult patient. Okay, so a difficult to treat asthma will be a patient who requires this, who despite reaching this may still be uncontrolled, or requires this to remain in control. The moment you try to step down, the patient becomes uncontrolled. So that is a difficult to treat asthma. Whereas a severe asthma is a further subset of difficult to treat asthma. It means asthma that is uncontrolled despite adherence with maximal optimized therapy and treatment contributory factors, or that worsens when high dose treatment is decreased. Okay. So if we were to see from all these, supposing this is a cohort of patients, around 1/4 will be uncontrolled asthma. Of these 1/4, around 70% will be around difficult to treat asthma, and among difficult to treat asthma, around 3 to 4%. That means 3 to 4% of the total of these will be severe asthma. Okay, so how do we treat? How do you approach these? This entity, this category of asthma. First thing, confirm the diagnosis. Again, go back to the basics, confirm your diagnosis, and look for other differential diagnosis. Okay, look for any factors that may contribute to the difficulty in controlling asthma or treating asthma. Whether if there's incorrect inhaler technique, which is the most common. Okay, the patient is not adherent, has other comorbidities such as obesity, gastroesophageal reflux, obstructive sleep apnea, or chronic rhinosinusitis. There is modifiable risk factors such as there may be triggers at a workplace, then there may be triggers at home, including somebody else at home who's smoking, so the patient gets exposed to secondhand smoke. Okay, so all that. If there's allergen exposure, you do as a skin prick testing or IgE levels. Then if there's a history of overuse of SABA relievers without the use of ICS, because now the recommendation is that for reliever medication also you need to add an inhaled steroid, not just a short-acting bronchodilator. Okay, if there's any medication side effects which have caused the patient to reduce his use of these medications. Okay, then you optimize the management. You educate the patient on asthma, look at the inhaler technique, educate them on inhaler technique, treat the comorbidities that are present or any modifiable risk factors. If there's occupation related, you can advise that the patient may stay away from that workplace for some time, give a medical certificate, look at the house, see the house, look for any, ask them to clean, like if they have carpets or pets, try to stay away from pets and all that. You can then consider for non-biologic therapy, such as adding ditropin, which is a LAMA, adding a glutathione receptor antagonist if it has not been used before. Then you can also consider non-pharmacological inventions, that is smoking cessation, exercise, weight loss, mucosal clearance exercises. Okay, or then you can even add high dose of ICS. Okay, then you review the response. Is the asthma uncontrolled? If the patient is getting these controls, then you start stepping down the treatment. Okay, if after stepping down he then becomes uncontrolled, then you can label this patient as severe asthma, and that's the time when you can send the patient to a pulmonologist or any other respiratory specialist. Okay, and if he continues to improve, if there's improvement, then you continue to optimize his management. So for severe asthma, again, once you optimize his management, despite all these measures, he still has uncontrolled symptoms, you refer to a specialized center, assess this is where specialized therapy comes in. You assess the different phenotypes, okay, and look at other factors that can contribute to the symptoms. See if there's any type 2 inflammation. Could the patient have a type 2 inflammation, which is manifested by a more allergic manifestation? So you'll have eosinophils which are high, pheno which is elevated. That's the sputum eosinophils, okay, and the asthma is clearly allergen driven, and then you need a maintenance steroid. Okay, then if there is evidence of type 2 inflammation or allergic inflammation, then you can consider you can do your other tests, such as increasing your inhaled steroids. Then you can consider for acute eosinophilic respiratory disease or ABPA. Then you work up along that line and treat accordingly. If it's ABPA, you can even start antifungal therapy, and you can at the same time then if there's still no improvement, you can consider biologics. Biologics include anti-IgE and anti-IL-5 and all that. We will discuss about that. Okay, then other investigation that you can distinguish is basically to rule out other causes which may be causing worsening other than asthma. So you look for other comorbidities, then you look for infections, you do CRP, IgA, IgM, look for fungal assay, look for other causes. Okay, then you consider need for social, psychological support, and then if there's no evidence of type 2 inflammation, then again, review the basics. Look at the differential diagnosis. See if there's anything that has been missed. If there's anything other than the asthma which has been missed, which has not been treated, look at the inhaler technique, look at comorbidities and other side effects. Then this is where you can consider other investigations, such as HRCT or bronchoscopy if you think that the sudden onset wheeze is not due to asthma, or the response is not, if the patient is not behaving like an asthmatic patient. So you can consider all these other investigations. Okay, and consider for bronchial thermoplasty if it is a non-allergic type of manifestation, and then we can consider bronchial thermoplasty. I'll be telling you what is bronchial thermoplasty later on. So now coming to the biologics. So here, if you feel that is more an allergic type of reaction, allergic type of severe asthma, you can consider for biologic therapy. The biologics include multiple. Most common is anti-IgE. The currently approved anti-IgE is omalizumab for children anyone above age of 6 years. It is given by subcutaneous injection every 2 to 4 weeks, and the dose of this drug is based on the weight and the serum IgE level. Very important to know that how you calculate the dose of omalizumab is based on the patient's weight and what is their baseline IgE level. Okay. So basically, it binds to the FC portion of free IgE and prevents the binding of IgE to its receptors, reducing the free IgE and therefore downregulating the receptor expression, because what we know is that the once IgE binds to receptors, it then activates the mast cells, and that is where the problem arises. Once these mast cells get activated, they immediately release all these potent bronchoconstrictor mediators. Your histamine, your bradykinin, and all that is being released by the mast cells. So the action of omalizumab is to reduce, prevent the binding of IgE to its receptor, and thereby inactivating IgE, which secondarily inactivates mast cells. Okay. Adverse effects of omalizumab is injection site reactions, anaphylaxis can also be seen, and minimum duration we can give a trial of at least 4 months. So weekly for at least 4 months, and then we assess the response. So this is anti-IgE, this is omalizumab. Okay. Second group is your anti-IL-5 or anti-IL-5 receptor. This is especially when we have very high eosinophil count. Okay, so it is because these will act on IL-5, and IL-5 acts on the eosinophils. Okay, so the currently approved medications include mepolizumab, which is an anti-IL-5, which is given 100 milligrams by subcutaneous injection every 4 weeks. Benralizumab, which is an anti-IL-5 receptor alpha. So okay, so mepolizumab acts on anti-IL-5, acts on IL-5. Benralizumab acts on IL-5 receptor, which is given 30 milligrams by subcutaneous injection every 4 weeks for 3 doses, then every 8 weeks. Okay. Then another one is for adults above 18 years, you have another anti-IL-5, which is reslizumab. Reslizumab is given at a dose of 3 mg per kg by IV infusion every 4 weeks. Okay. So mepolizumab and reslizumab, they are anti-IL-5, they bind to IL-5. Benralizumab is the only one which binds to the IL-5 receptor alpha subunit, leading to apoptosis of the eosinophils. So basically, they cause a marked reduction of the eosinophils, and if there's decreased circulating eosinophils, then there is definitely decrease all the effects due to eosinophils, such as the releasing of the cationic protein, and all the others will be decreased. Okay. Adverse effects of all the anti-IL-5s include the injection site reaction, which is common to all. Okay, anaphylaxis is less common than omalizumab, and most of the time these drugs are anyway quite safe. Then the third one is anti-interleukin-4 receptor. This is dupilumab, which is anti-interleukin-4 receptor alpha, at a dose of 200 to 300 milligrams by subcutaneous injection every 2 to 3 weeks for severe eosinophilic or type 2 asthma. Okay. Dupilumab is also indicated for treatment in moderate to severe atopic dermatitis and may improve nasal polyposis. So these are the biologics that you have right now. You have your anti-IgE, anti-IL-5, anti-IL-5 receptor, and your anti-IL-4 receptors. So these are at present indicated for severe asthma. So each has its own criteria of when to use them. So you have you have the biologics which act on 3 different pathways. So you have to be judicious in your decision on which to use. Your decision can be made easier by looking at the eosinophil count, your IgE levels. Okay, so these will help you guide on which biologic to use for which patient. Okay. Now coming to the other modalities of treatment, there are commonly other modalities that we have are your SIT, which is your specific allergen immunotherapy, and bronchial thermoplasty. Okay. So specific allergen immunotherapy or SIT, the basic concept behind SIT is that the key component of the pathomechanisms of allergic diseases is the production of the Th2 cytokines. If you remember from the first lecture, there's a production of Th2 cytokines, generation of allergen-specific immunoglobulin IgE. And this IgE leads to activation of the mast cells with the release of potent mediators, which in turn elicit the acute allergic reactions and initiate the development of chronic inflammation. So what does allergen immunotherapy do? It induces long-term remission of allergic rhinitis and allergic asthma, and it prevents the onset of new sensitizations. So what happens here is that it acts on the immunological memory, and therefore has direct and indirect effect on T and B cells. So what does we know the mechanism here? Allergen with an allergen presenting cell goes to the T lymphocytes, generates a Th2 type response, leading to production of interleukin 4, interleukin 5. Interleukin 4 will then stimulate the B cells, Ig and B cells, and mast cells, which then cause the allergic inflammation. So what does immunotherapy do is it acts here. So it acts on the naive T cells. It desensitizes these naive T cells to these allergens. Therefore, once they're desensitized, and at the same time, it will also activate the Th1 response, which again is more of an IgG response, which decreases the allergic inflammation. So in the end, with allergen immunotherapy, it activates this pathway and suppresses the allergic pathway, and in that way it can produce long-lasting effects, decreases the allergen sensitivity, allergic reaction of the patient, and thereby decreasing the symptoms of asthma. And if you decrease all these mediators, you can therefore decrease the development of chronic inflammation and airway remodeling. So what are the indications of allergen immunotherapy? If there is IgE, you are sure that it is an IgE mediated respiratory disease, okay? And the causal role of allergens is well established. So not only is the IgE levels high, you've also done an allergy screen, and you've seen that the patient is allergic to a number of other allergens, including your house dust mite, your cockroaches, your other fungi. So the patient definitely has evidence of strong allergies by your skin tests, and at the same time the IgE levels are elevated. Okay, in addition to that, the patient has clinical symptoms and is inadequately responding to drug treatment. So with conventional therapy, it is still despite being on steroids and all, is still not responding. And or if the patient is unwilling to take other medications such as biologics and all your biological agents, the patient is not very willing, then you can try the allergen immunotherapy. Okay, contraindications, basically if there's uncontrolled or severe asthma, if the patient is taking beta blockers, if the patient is having other medical or immunological disorders, children less than 5 years is a contraindication, pregnancy is again another contraindication, and patients unable to comply with immunotherapy, because immunotherapy protocol, immunotherapy once we start, it is a long-term therapy. The actual duration of therapy is actually 2 to 3 years. Okay, before we can consider whether the immunotherapy is successful or not successful, the treatment duration is at least 2 to 3 years. So the patients have to be motivated. They have to be motivated that they will continue the therapy for at least 2 to 3 years before we can even consider starting that therapy. So how do we give SIT? There are two main ways in which we give SIT. One is the standard modality is the subcutaneous route. Subcutaneous route also, when we give the therapy, is very similar to how we do the allergic testing. The only thing is that here, instead of giving a panel of different, you give one specific allergen. Basically, you desensitize with one specific allergen. You can give subcutaneous in any route. You can give it over the chest, over the back, in the forearm, in the arm. Okay, so that is the subcutaneous route of immunotherapy, what we also call as the SCIT. Now, in addition to that, recently we've also been able to use another modality, which is the sublingual route, or we call it the SLIT. So now we have two routes, basically your SCIT and your SLIT. So in asthma, both forms of therapy are recommended, whereas in Hymenoptera venom allergy, only SCIT is being recommended for treatment. So if you see the difference between sorry, it's hanging. Yeah. So if you see the difference between subcutaneous and sublingual with rhinitis, both of them are equally efficacious. If you understand this grading, this is basically how we grade the level of evidence and the efficacy. One is highest evidence with strongest, basically the highest and the strongest evidence of efficacy. So clinical efficacy in rhinitis, both of them are equally effective. In asthma, both of them are equally effective. In children, rhinitis, equally effective. Prevention of new sensitizations, we find that subcutaneous therapy is better than sublingual therapy. Long-term effect, again, there's more data on efficacy with subcutaneous route rather than sublingual route. So, and for prevention of asthma, again, both of them have equal data. Okay. Okay, so these are the two modalities of allergen immunotherapy, your SLIT and your FCIT, slit and slit, sublingual and your subcutaneous. Now coming to bronchial thermoplasty. What is bronchial thermoplasty? Bronchial thermoplasty basically is a bronchoscopic procedure for patients with severe asthma, where the main aim of bronchial thermoplasty is to reduce the smooth muscle mass. So this has nothing with your mediators and all that. The only thing that bronchial thermoplasty will do is it'll try to decrease that mass, because if that smooth muscle mass, if because of inflammation and all that, you have a very high, so if there's too much muscle, the power of bronchoconstriction is very high. So the aim with bronchial thermoplasty is reduce that mass. Therefore, it diminishes the bronchoconstrictive effects and helps, and theoretically should help in improving asthma symptoms. So how do we do bronchial thermoplasty? We give a controlled heat. So this is a thermoplasty catheter that is introduced bronchoscopically, and using this catheter, we deliver controlled heat into the airways via radiofrequency electrical generator. Okay. Usually we perform 3 to 4 bronchoscopy sessions, 2 to 3 weeks apart. The first two sessions treat each lower lobe separately. Okay, so you go to the right and left lower lobe. Third session then uses the upper lobes. Okay, radiofrequency energy is delivered in a systematic fashion at 5 mm intervals, starting from just beyond the endoscopic visual limit to the proximal lobar bronchi through this catheter. Okay, so this is the bronchoscope. We've used the bronchoscope. We visualize the airways here. You can see that here we visualize the airway. Then once we visualize the airway, we push the scope as far down as it can go. Then through the working channel of the bronchoscope, we then push out the catheter. This is how it would look bronchoscopically. Then we expand the catheter and apply radiofrequency and heat. So what it does here is, it burns the mucosa up to the level of a smooth muscle, and once this burns, it basically generates areas of fibrosis. So once these areas of fibrosis occurs, there will be lesser muscle mass here. So basically what it does is it makes that place hard. So once it becomes hard, there's less chance for that to constrict. Okay. So if there's less chance of bronchoconstriction, therefore that is better for patients of asthma. So the indications, again, adult patients with severe persistent asthma who remain symptomatic despite maximal medical treatment. Okay, you should remember bronchial thermoplasty should not be used as a substitute for medical compliance. Contraindications for bronchial thermoplasty is presence of any implantable electronic device, any comorbid conditions that increase the risk of the procedure, obesity, underlying COPD or COPD asthma overlap. Okay. Any deformity in the airway, any past infections, tuberculosis, or anything like that which already compromise the airway, all that should not be is a contraindication. And FEV1 greater than 65%, that is mild to moderate disease, is not an indication for doing bronchoplasty. Okay, and in children, the procedure has not been tried, and therefore it is still not approved. Okay, so these basically concludes our lectures on asthma. There are still many other topics which are there. Yeah, you have your asthma with comorbidities, asthma with COPD, asthma with heart failure, asthma with obesity, asthma with pregnancy. But all these, I think, they are beyond what is required for you. And this is basically, I've covered all the important topics that you need at your level. If there's anything extra that you need to know, then my suggestion is read well, do an MD in medicine, and then do a DM in pulmonary medicine. Then you'll know more about asthma and COPD. Okay, thank you. I think exams are coming up from Monday, if I'm not mistaken. Wishing you all the best. And we'll hopefully be able to continue these classes after your exams. Okay.